Good morning, good afternoon, good evening, wherever you are in the world. Thank you for joining us on our Wednesday YouTube video. Today, I thought we would dip our toes into the water regarding evaluation, assessment, and treatment. So I'm going to talk briefly about those things. I'm joined, as always, by my beautiful wife and practice manager, Lynn, who may chip in with some questions as we go along. And she's here to keep me on track and I don't get too clinical and too confusing. Try and make it as understandable as possible. So I'm kind of thinking about the US, the UK and Canada when I'm talking this morning, okay? So evaluation, what happens if we suspect that our granny or our mum or dad or other family member or friend is having some cognitive challenges, some cognitive issues, and we manage to get them over to the doctor? What's going to happen? The doctor's going to do some preliminary tests and maybe show some concern that the person is having some cognitive issues, and then they'll send them over to the correct specialist, which is the neurologist. So the neurologist will be looking at determining whether the person is going to be experiencing right now some kind of neurocognitive or neurological disorder, such as Alzheimer's disease or Parkinson's. So here's a brief rundown of what to expect during these processes, during the evaluation. Typically, you would start by looking at something called a cognitive function test. It's a brief test, and on these tests, one can score a maximum of 30. And if people score within the range of kind of 27 to 30, we're looking at normal range. So we wouldn't be worried too much about that, and we might just be keeping our eye on people and observing them. But I have here with me 3 different cognitive function tests that we might use. And I'm aware that in the UK, there are some other ones as well that GPs might use, which is a quick GP cognitive test to ascertain whether or not the person might be needing to go to the memory clinic. But I don't have that one with me. I'm going to concentrate on the main ones that I use and the main ones that they use in neurology. So let's think about the first. The first one is called the MOCA, and it looks like that. I hope that's on the screen okay. Yeah, perfect. There are different questions, as you can see, and you're testing different parts of the brain, different areas, from visual, spatial, all the way down to orientation. And that's called a Montreal Cognitive Assessment. Okay, now that is my go-to. That's the one that I use more than anything else. And for me, I will use that to find a baseline of where that patient is, because they've already been diagnosed before I see them. I'll explain my role in a little while. If they go and see the neurologist will use that to determine whether or not there is a need to do further exploration. And if they do, then what may happen, depending on where you are in the world, okay? This is a battery of tests that people go through. There is a likelihood there will be an MRI. There is a possibility that there will be a spinal tap, and there is a likelihood there will be bloods taken. So those are the things that the neurology department will be looking at. And the reason why they're taking all those tests and checking all those things is to determine whether or not there is a neurological or a neurocognitive disease or disorder taking place. All those things will confirm the suspicion that the neurologist might have, whether it's Alzheimer's disease, whether it's Parkinson's, MS, whatever. There's a whole list of neurological, neurocognitive things that can go on. Why would they take a spinal tap? Why would they do that? That will show whether there's any amyloid plaque in the brain. and it would confirm a diagnosis of probable Alzheimer's disease. And the beta amyloid, that plaque in the brain, is what kind of causes the problems, and it's that needs to be addressed. That's specifically with Alzheimer's disease. So there's a whole bunch of reasons why all these tests are taken. One other thing, an indicator is something called an APOE gene, an apolipoprotein gene. And if someone is found to have an apolipoprotein 4, then that increases the risk of developing Alzheimer's disease. And I'm going to talk a little bit more about that as well in a moment. So that's the MoCA. The next one that we might use is called the SLUMS examination. And it's very, very similar to the MoCA, just a few differences, but not much. You're doing the same thing, you're testing the same parts of the brain, you're looking for any potential evidence that there may be a cognitive issue going on. And that's the St. Louis University evaluation, because that's where it was developed, created. On both those tests is something that we call the clock test. And there are 3 things we're looking for with the clock test. One is being able to draw a clock face as accurate as possible. The other one is putting the numbers in the clock. And then the other one is putting the hands at a particular time. On the MoCA, it will say 10 minutes past 11. And I think on this one, it might have a different time. But it's basically testing whether the person can do that. Now, my personal belief is that as years go by and we no longer have clocks and we're not really using the traditional clock, we're going to have to change that test because people won't know how to do it. It's like the old payphone, the telephone. You know, young kids today won't know what that is. So these things continually have to develop and change as the years go on and the generations come by. The next one, the third and final one that I want to talk to you about is called a mini mental state examination. Now, this is the old one that's been around since Methuselah was a boy. It's been all around for a long, long time. But again, you can score 30 points and there's a bunch of questions which are very, very similar. But on the MMSE, people are given a specific amount of time to respond. For example, there will be a question is say or repeat after me, or say, I can't do number 5 because it gets ahead of itself. But for example, it would say spell the word world backwards. And it'll give you maybe 10 or 30 seconds to do that. I find this a little bit ambiguous because with the majority of people who are experiencing a cognitive impairment, they need usually around about a minute to process what you've just asked them before they can answer. So maybe this is the reason why it is so many seconds, because the person hasn't been able to process it. Whereas if I say to you, repeat to me, no ifs, ands, or buts, you should be able to do that immediately. No ifs, ands, or buts. So those are 3 cognitive function tests that may go along with the spinal tap, the MRI, the blood tests, and any other, physical evaluations and assessments that the neurologist is likely to do. So let's say we've done all these tests and we come to the conclusion now that there is a high probability that you've either got mild cognitive impairment, which very often, but not always, but very often is the early sign of a dementia type neurocognitive disorder. Okay, so mild cognitive impairment. And it's at that time, if it's established that there's a mild cognitive impairment, that's a great time to start treatment and therapy. Because like everything else, the sooner you can start treatment and therapy, the better the outcomes. Alternatively, it might show that people are in the early stages of Alzheimer's disease, for example. So what is the choice? What are the choices then? What are the options here? Let's start with the oldest medications that we used. So I'm just going to refer to my notes because there's a little bit of history here that I want to talk about. One of the first things you would think about using is a drug called donepezil. And donepezil is a medication that is called an acetylcholinesterase inhibitor, or to make it easy, a cognitive enhancer. And what that does, or the aim and objective is to slow down the progression of the disease. It is not a cure. It will not cure the Alzheimer's disease. It will slow it down for a period of time. It's not a long use acting medicine. But for some people it is useful, for some people it works, for some people it helps. For others it doesn't. So that's usually where people think about that. They think about Aricept, donepezil being the first drug of choice. There are two others in that same family who are acetylcholinesterase inhibitors, cognitive enhancers. One is called rivastigmine, and the other one is galantamine. And galantamine is very interesting. I'll talk a bit more about that in a moment. But in the UK in 1997, Aricept, donepezil was licensed for use, and that happened in 1996 in the US. Now, usually, where dementia is concerned, the UK are usually ahead of the game in a lot of things. But with medication, that isn't the case. And I'll explain why that is in a little moment. Rivastigmine was licensed in 1997. So prior to all this happening, there was nothing. So when I graduated in last century, my God, 1992, there were none of these medicines. There was nothing available. So it wasn't until the late 90s that we started seeing this. However, when it comes to galantamine, a really interesting thing about that is in Bulgaria, sorry, I've lost my train of thought. Lynn was giving me pointing at me for some reason. In Bulgaria in 1958, galantamine had been discovered from the snowdrop plant. If you know what the snowdrop flower is, the little white flower, that's where it's extracted from, the galantamine. And in 1958, a Bulgarian pharmacist, discovered that it was quite useful. And he discovered it because he saw some people rubbing their heads with the flower. So he thought, what's going on there? So he decided to experiment and extract from it what the chemical was. And it turned out to be a useful drug for use in anesthesia and also for treating neuropathy, neuropathic pain. So that was interesting, but it didn't get licensed for use in our field until 2001. So that's interesting. And that was in the US and the UK. Okay. So those are the three main usage. Get my words right here. The three main medicines that would be a medicine of choice in terms of active clinical treatment. Today we have some monoclonal antibodies. And this medicine is given as an infusion. And again, it's indicated for early mild Alzheimer's disease. And it's a medicine that clears up that plaque that I spoke about earlier, the amyloid plaque, the amyloid beta. It cleans it up in the brain. And the hope with that medicine is that it will, again, slow down the progression of the disease. Will it cure it? We're not too sure yet because it's brand new, and it is only currently available in the US as a medicine that can be prescribed through the insurance company. as most people may know, the US, people use insurance. People have, the treatment is very, very expensive. So everybody here in the US are covered by insurance policies. And it's only recently, these last few months, that the insurance company have approved it.
Are you talking about lecanemab?
Okay, so yes. The medicine has only just been approved by the drug agency here, the FDA, and there are 3 of them. And one of them that Lynn has just mentioned there is Leqembi, or lecanemab. That is the one that is currently being used for people actively. Okay, so we're going to wait and see how it's working. As always with medicine, with any medication, any treatment, any therapy, there are always potential side effects. And one of the side effects with the monoclonal antibody infusion medicines is bleeding in the brain, microhemorrhaging, or swelling in the brain. So regularly, as these infusions are being given, MRIs are done intermittently to make sure that everything's good with the brain. There are a couple of other medicines that are being trialled and tested that are also monoclonal antibodies. Now, this is in the US. In Canada, that medicine is only given as part of drug trials. In the UK, it won't be available, if it is approved, until 2025. So when I was saying that a lot of the times the UK are ahead in terms of dementia therapy and treatment and stuff, not where medication is concerned. And this is because, of course, the National Health Service have to fund those medicines. And those medicines are very, very expensive. So currently, it's being evaluated by, there's 2 agencies. There's the Medicines Agency that looks at it and decides whether or not it can be approved. If it is, that'll be decided in 2024. And then the National Institute of Clinical Excellence, NICE, they will look at it and they will evaluate it and they will make a decision whether it can be made available through the National Health Service. When memantine, which is another medicine I'll talk about, memantine is a medicine that is used for later Alzheimer's. So when the other medicines stop working, you might look at using memantine, which is a neuroprotective agent. It's a different chemical than the other 3 that we spoke about. When that was first made available, it took quite some time for it to be approved. The Scottish Drug Agency would not approve it for a long time, and that was because of the lack of efficacy, the lack of research that demonstrated its use, its positive benefits. But eventually it was, so it took a little bit more time in the UK for memantine to be available. And it became available in around about 2003. So that is another medicine that is available. I spoke earlier about apolipoprotein 4. If somebody has an apolipoprotein 4, it may, not necessarily, because it depends on the prescriber, but it may prevent somebody from receiving the lecanemab, Leqembi. That's because there's a greater risk of bleed and larger bleeds. So it's a bit of more of a risk for people with APOE4. But again, it doesn't mean you can't have it. It's down to the prescriber and their decision and choice whether to use it or not. Okay. So we've talked about the cognitive evaluations. We've talked about potential treatment. What happens with that? What else is there? Treatment and therapy isn't just about medicine. It's about continued support. It's about follow-up. It's about monitoring, observing, and we're trying every opportunity to help improve quality of life of the individual who has been diagnosed with the disease and their family and other people that are on that journey. So as part of the neurological team, they will maybe do a neuropsych test, a neuropsychological test, 6 months or 12 months post commencement of treatment. And what they're looking for is to find out whether or not there's deterioration, and if there is, in what areas is that deterioration. The other thing that the neurological team will do is suggest brain health, diet and nutrition, brain health exercises, diet and nutrition. The mind diet that we've already spoken about in one of my previous videos is usually the one that is prescribed. And so there's a whole bunch of continued support going on with your diagnosis. What is my role? Maybe we've probably never discussed this, have we, in our videos? My role in all of this, I specifically focus on 3 key areas. One is cognitive behavior therapy, in which I am trained. The second is hypnosis, hypnotherapy, in which I am trained. And then the third area is brain health and advice on diet and nutrition and those kind of things. Those are mainly the 3 things that I focus on and I work with patients who have been diagnosed with a dementia or a neurocognitive type disease disorder. And we see some humongous benefits. We've already spoken in previous video about hypnotherapy, we've spoken about diet and nutrition, and we've also spoken about my rule of 7 for brain health exercises. All those things combined make a real difference, because one of the first things that tends to happen when somebody gets a diagnosis, and many of my patients confirm this, is that their self-esteem and their self-confidence hits rock bottom. You know, they've been given this diagnosis, and many people don't really understand what it means. You know, a lot of people see it as being, okay, that's it, I'm going to get worse, I'm going to get worse, I'm going to get worse. Not necessarily so. Neuroplasticity of the brain, I think we've talked about this before. Having learned about neuroplasticity of the brain means that we can do something about it. We can change things. We can lay new neuronal pathways down. We can relearn lost skills. We can learn and retain new information. And we see this all the time. In my practice, see it a lot. And how I see it and how I do it is by using a combination of those 3 things: hypnosis, cognitive behavior therapy, and brain health, with the mind diet and the Mediterranean diet and the DASH diet all combined together. So that's where I am with all this, and I know Lynn has some questions that people have asked. So fire away, Mrs. Nightingale.
Okay, great. So let's say somebody comes to you for the first time. Are you going to do a cognitive assessment the first appointment or second appointment?
I decide that on A, where the referral has come from, and B, when they last had that cognitive function test. So if somebody comes over to me and they've just seen the neurologist last week and they had a MOCA or a SLUMS or an MMSE last week, then I won't do it. I will take that one and use that one as my baseline. If it was a few months ago, then yes, I will do usually a MOCA. But I will try and find out what cognitive assessment tool the last person used, and I will use the same one. And that'll give me my baseline of where to start in terms of treatment and therapy.
So how can a 1-page or so test give you enough information to know what to do and how to plan your therapy?
Okay, so let's go back to the MOCA, because that's my favourite one. I like the MOCA. Oh, and by the way, just in terms of the MMSE, sometimes that is used in trials. They will use the MMSE, and so there's a medicine at the moment that is being evaluated that is available for treating MS, and it demonstrated that it was helping people's cognitive function. people with MS. So now there's some trials looking at that medicine, see if it's useful for dementia. And the cognitive function test that is being used during those trials is the MMSE. So let's just go back to answering Lynn's question here about the MOCA. How do I determine my therapy based on this? So, as we said, it covers various areas, and I'm looking to see where the person is struggling. Where is the challenge? Is it with orientation? Is it with speech and language? Is it with visual spatial awareness? Is it with numbers? Is it with math? What is going on? What is the challenge? What is the difficulty? So I will identify through this process where the person is having an issue. With mild cognitive impairments, with Alzheimer's disease, very often your immediate memory or working memory or short-term memory, as it's called, people will have a struggle with remembering the words. It's 5 words. Face, velvet, church, daisy, red. And as you continue the process and then go back and ask them to recall those words, very often they can't. So you pretty much know that, right, I'm working with short-term memory here. And as we've spoken before, the hippocampus is part of the brain responsible for quite a few things, but memory is one of them. And so if you can use brain health exercises such as the rule of 7 and other things, then you can start working on the hippocampus. You can start helping people prevent the shrinkage of the hippocampus and sometimes help it to grow again. And this is all about neuroplasticity of the brain. And I'm currently seeing some really, really good outcomes from people doing this brain health stuff repetitively, because it is the repetitive activity that helps lay down those neuronal pathways. So that's how I determine whether the person needs help with managing anxiety, managing depression, which we can do through cognitive behaviour therapy and hypnosis, and whether brain health exercises, I will determine what brain health exercise they need to do from that. That's how I use it.
Can someone's score change?
Oh, absolutely. That's the whole point of it. The whole point of people coming to see me is so that we can change that, so that we can improve the score, so that we can, when somebody sees that they have changed even 2 points, just 2 points, that gives them such a boost. It really improves their confidence and their motivation to continue because they see results, just like everything else. If we're losing weight and we see the results and we feel the benefits, we're encouraged to continue. If we work out in the gym and we see results and we see benefits, we're motivated to continue. And this is the same when we're working with people's self-confidence, self-esteem. They can start feeling better about themselves, and they're not. You see, a lot of the time, as people deteriorate, how do we know that it is because of the Alzheimer's disease, or because of self-confidence, or because of low self-esteem, or because people have always struggled on tests? When you are put under pressure in a test, and anybody who's done exams will know this, when you are put under pressure, it's different. You can sit at home and you can follow a study guide, you can revise your stuff, you can know it, and it's here, it's there, there it is. Walk into the classroom, sit down at the table, ready to do the exam, and could be blank for a few moments when you read that first question, because we're put under pressure. So hypnosis helps with that, because if we can instill greater sense of confidence and get rid of anxiety or lower it and put it where it needs to be, and we're going to talk about this possibly next week, because we might talk about something called the dementia triangle next week, and we'll address all this stuff in more detail. But if I see constantly, if people's self-confidence and self-esteem is high, they function so much better, just like everybody else does.
Is there anything else that a person can do to help support their loved one to do better on these function tests?
Yeah. Work with them, support them, encourage them, praise them, look at the good things. Really focus on the positives, really focus on that, and focus on the individual's strengths, their abilities. And I say this all the time, just because, and I'd make no apologies for saying just because somebody has been diagnosed with a neurocognitive or a neurological disorder, disease, whatever you want to call it, does not change that person massively. You are still that individual. And the most important thing to protect is your identity. Whether you are the person with the diagnosis or a member of the family, husband, wife, son, daughter, whoever you may be, if you become a carer for that person, remember your identity. You are still that individual. You are not somebody who's got dementia. You are somebody. That's it. You're still somebody. So try to focus on all the positives and all the strengths, and don't de-skill people. Don't make a judgment that somebody can no longer do something. Don't do that. And it's easy to do, because it's easy for us to say, right, I'm going to do that now because I can see you're struggling with it. Support the person to still do it, whatever it might be. So maybe it's making a cup of tea. Maybe we're in a position where we can't really handle the kettle. So there's a risk that somebody might get burnt. They can get the cup, they can put the tea bag in the cup, or they can put the tea bag in the teapot, and somebody else can pour the water, and then the person can deal with the rest of it. So always focus on what the person can do, and really make that yes, well done, that's fantastic. I knew you could do it. See, nothing to worry about. And on another occasion, we're going to talk about how difficult it is when we're talking about people's driving ability and the implications of that and the pre-planning for that. We can pre-plan for those kind of things and put strategies in place. So always focus on what the person can do. Any more?
No.
We're done? Fabulous. Well, I hope you found that useful. I'm sure you have. Any questions, as always, please send them to us. Ask us on YouTube, on this channel, or send us an email. You can find those details on our website, drdanielnightingale.com. Please, please, please share this video, share this channel. The more people we can reach, the better. The better education we can get out there, the more understanding people have of dementia and the lack of fear. There's nothing to fear. Don't be afraid. If you feel that something's happening, if you feel that your memory is changing, please go and see somebody immediately, because as I said, the sooner we can deal with it, the sooner and the better the outcomes are going to be. And remember, no soda over Thanksgiving. Have a happy Thanksgiving, guys, and I will speak to you next week.